tube, and the secretions are in the airways, and the patients have gross atelectasis. And, intensivists wonder, how come my patients don't get better? It's because they're not clearing their secretions. And why are they not clearing the secretions? What percentage of the time when you suction through an invasive airway tube do you get the secretions from the left lung? Less than 10%. This is why over 80% of pneumonias for ALS patients are in the left lung. Because even if you suction through a tube or suction through the upper airway, you almost never get the catheter into the left lung because the airways go like this. So the catheter goes in there. You see, it doesn't
Question. Can you direct the
Yes, there's something called a directed catheter, and if you're very careful, you can try to get that catheter into the left airways, but people don't do it. Very rarely is it done, but it's true. There are directed catheters, and it can be done, but I've never really seen it done. People just don't do it. They let the secretions build up, and they say, "Oh, you need a bronchoscopy," or you need to be intubated, or something like that. Have you ever seen anybody use a directed catheter? I know they exist.
I'm not in that.
Oh no, that's true. Okay, yeah.
Dr. Bach, I'm
Yeah.
not sure if this is appropriate time to ask you, but Dr. Bach, I'm
Yeah.
not sure this is appropriate time to ask you, but I'd like to know if my mother, who's on has a trach, how the cough assist can help her. She's in the hospital with pneumonia just now. She's practically over it, but just wondering about that. So she's
Of course,
80.
you use it through the trach, of course. You get better much quicker that way, of course.
So I don't know what that device looks like. Do you have a picture or information,
We have one
literature
here.
on it?
We'll take it out later.
Okay,
Later
thank
on,
you.
we'll show you. Yeah.
All right.
No, it looks exactly like the Trilogy ventilator. Did you ever see a Trilogy ventilator? Well, what ventilator is she using? Ah, the LTV. Yeah, that's a very good ventilator, but it's noisier than the Trilogy. It's old now. Yeah, you know why? Because it only works with an active circuit, which means you have to use the right method to ventilate people on non-invasive ventilation. But everybody with a trach is on an active circuit. What an active circuit means is that the circuit just has an exhalation valve. It's not important. The point is that all therapists think that when you have a trach tube, you have to be with an active circuit on a ventilator. And if you don't have a trach tube, or you're not intubated, non-invasive ventilation has to always be given with BiPAP at less than ventilatory support settings. So see, what doctors, pulmonologists, and respiratory therapists do not understand is that you can give total respiratory support non-invasively as well as invasively. And you can use the same ventilator and the same ventilator circuit to do it. But almost no doctor or therapist understands that. Why? Because a non-invasive ventilation, they always use low spans of BiPAP, which is not full ventilatory support, and they think that's all they can do. Nobody has this. Do you know how ironic it is for me? They have patients on BiPAP at less than ventilatory support settings, and then when the patient gets intubated, if you look at the ventilator, the pressure is always 20 centimeters of water. It's full ventilatory support when they're intubated or trached. If she has a trach and you look at that ventilator, I'll bet you that the pressures on that gauge are at least 18. I'll bet you. But when they're ventilated non-invasively, they're on 5 or 6 centimeters of water pressure, which is not going to sustain them. Eventually, they're going to get weaker. Why is it that doctors don't understand this? Now, you're not a medical doctor, but you understand what I'm saying, don't you?
I think so. I think so.
Listen.
Doctor.
Patients come to me, and I explain it to them. They understand it completely. When I explain it to intensivists, until I'm blue in the face, they don't understand it.
So, Dr. Bach, in interest of our time,
Okay.
No, but I wanted to. I know we're kind of running short on the presentation portion, but I also think that this room is kind of ripe with some questions.
They've been asking questions.
Yeah. But I want to make sure that today we take a minute. Yesterday, you mentioned about improving lung capacity while the muscles are, so the air stacking and the frog breathing.
Important.
I'd love for you to
It's
touch on that before we wrap up for today.
Okay. First of all, I have patients on non-invasive ventilatory support 24 hours a day for all this time. Okay? When patients are given oxygen, it makes them breathe more shallowly, and their carbon dioxides go up. Now, if you breathe shallowly, your lungs get stiff and small. If you ever seen a child sitting in a wheelchair, their knees get contracted, right? I mean, every respiratory therapist knows that if you don't do range of motion and put the joint through full range of motion, the joints get contracted. The same thing happens to the joints between the ribs. The muscles get contracted. The lungs and the lungs themselves, they shrink and they get stiff and small. Now, when that happens, you literally cannot normalize ventilation by using non-invasive ventilation initially because the lungs are too stiff. So in other words, when patients come to me and they've been on oxygen, we shut off the oxygen, their saturation goes to 60. So then we ventilate them with an ambu bag or with a ventilator. At, instead of at 300 milliliters of water, which usually is what they're on, we do it at 800. But first of all, it can cause some pain because their lungs are very small and stiff. And it often causes pain before we get the CO2 and the oxygen saturation back to normal. So the CO2 may still be 60 or 50 when it was 80 before because the lungs are so stiff and small that we can't even get a normal breath into them. So then what we do is we tell them to do lung volume recruitment. Now, there's two ways to do lung volume. There's active and there's passive lung volume recruitment. Let me see. Oh, this is a lady, 64 years of 24-hour non-invasive ventilatory support, and she works full-time as a rehabilitation counselor. She's normal from the neck up, but she has no movement below the neck. And she's not the only one. She uses a lip seal overnight for ventilatory support. If your nose gets congested and you're using nasal ventilation and the nose is clogged, your CO2 will go up, and you have to switch to being ventilated through the mouth. And there are a number of interfaces that can allow you to do that. These are lip seals, but there are other ventilator interfaces too. By the way, negative pressure ventilation is never as effective as positive pressure ventilation, and it causes obstructive apneas. So you really should never need it. It's another lady, 64 years of 24-hour non-invasive ventilatory support. In 1993, I reported 257 people on 24-hour non-invasive ventilatory support, including using a mouthpiece during the day. That was 1993. Doctors don't learn too quickly, do they? This was described in 1953. Oh, I'm sorry, but I'm, okay. ALS, all people on mouthpiece ventilation. Let me see. Okay, breath stacking. Forget this. There's trach tube problems with trach tubes. Yeah, Duchenne. Okay, well, every clinic should have to measure CO2, oxygen saturation, spirometry, and cough flows. Okay. Treatment goals here are to optimize chest wall elasticity and compliance. And this is breath stacking. You get an ambu bag, or you use a ventilator on volume preset. Remember, you can set a ventilator to deliver volume or pressure. BiPAP is a pressure-triggered ventilator, a pressure preset ventilator, essentially. Even with or without the EPAP, you're setting pressures. If you set a pressure, you cannot air stack. What do I mean by air stacking? Well, you get a volume of air and you don't exhale, you hold it. Okay, now, the machine wants to deliver another volume, but it's set for a pressure of 20 centimeters, let's say. So you're holding 20 centimeters in your lung right now with the first breath. As soon as you open your throat, the machine feels the 20 centimeters and it shuts off. You cannot get another volume of air. If you set a volume of 1,000, like you do by squeezing this bag, it gives you a volume of, let's say, 900 milliliters. You can hold that 900, and then it'll give you another 900 and another 900, because it's not limited by pressure. This is why we don't prescribe any pressure ventilation, BiPAP or otherwise, if a patient can air stack, because it's so important to inflate your lungs to their predicted normal capacity, okay? Why is that so important? So number one, they don't shrink, they don't get tight, they don't get stiff. It's easier for your diaphragm to work and your vital capacity goes up if you have compliant lungs as opposed to stiff lungs. Also, with the deep breath, you can shout, you can talk longer, you can cough stronger, okay? And because of that, we all put every patient on volume preset ventilation. And if the lips are the limiting factor, we use that lip seal, frog breathing. Okay. This is, I want you all to know how to frog breathe before you leave here today, because, you know, frogs are wonderful little critters. Some of you probably have dogs and cats at home. You've never learned a thing from a dog or a cat. Trade them in for a frog, okay? You know, a frog will hop alongside the wheelchair, you know, and you can learn how to breathe from a frog. You can't learn how to breathe from a dog, you know? Frogs do not have diaphragms, so they actually breathe with their tongues. And a couple of the patients we went by there woke up at night, frog breathing, before they realized that their respirators were no longer functioning. If you're being ventilated through a trach tube, you're dead if your alarm doesn't go off. In the old days, they didn't have alarms, okay? So one of the big reasons why I like to take the trach tubes out of ALS patients, and everybody else for that matter, is so that they can learn how to frog breathe. 70% of people with good bulbar muscle function, like spinal cord injured patients, polio patients, can frog breathe sufficiently to breathe all day long without a ventilator, even when they have zero vital capacity, including me. So if I get hit by a truck here and I am still conscious, I can ventilate. And Mark here, he has a neck that frogs would be envious of. Now watch him frog. Watch us both frog together. You know, I always say that the family that frogs together stays together. You know.
You can't laugh and frog breathe.
No, that's true. That's true. Mark, I think you're losing it. First of all, you're using your diaphragm. I told you to stop doing that. Look. He was great before. Yeah. See, I told him he was so good he could even do it with his mouth shut through his nose, and now he's getting carried away, you know? No, not everybody. You should all do it. Come on, let me see you do it. Let me see you frog together. You're doing too much and not... It's the throat here, you see? Well, you're doing it. You're doing it. But you're not that efficient either. You got to put more emphasis back on the throat. No, you're using your diaphragm. You're cheating. You're not using your diaphragm? Okay. See, again, you're doing it, but you don't have the same movement that Mark has at his best. At his best. Yeah. So the point is that ALS patients, when they have good bulbar muscle function, even if the vital capacity goes down, they can frog breathe instead of using a ventilator.
Okay.
Oh.
We're gonna need to wrap up for now. Dr. Bach, thank you so much for your time.
I the website.
You will show the website, yes, please.
Yeah, you can refer your physicians to the website. A medical student set up a website for me about 2 years ago. Wow. Yeah, that's it. BreatheNBS.com. Right. Yeah, also BreatheBB.com. That's a pneumobell, by the way. Extubating people. See, you'll need to give these articles to your doctors for extubating, learning how to extubate. This one here is a paper we published in Chest in 2010, and there are 15 of the patients were ALS, and then we published another one on 100 patients in 2015. This is an ALS patient whose trach tube we removed. She was on trach ventilation for 2 years, and we removed her trach tube, and she went another few years on non-invasive support. But she was continuously vent dependent for 2 years when we took her trach out. And another patient, same kind of thing.
So-
It's too bad we don't have time to talk about life satisfaction and quality of life.
So actually,
Oh,
there he is. There's the website. Awesome. So thank you, Dr. Bach.
Yes, no, you're
Thank you.
welcome. You're welcome.
So, yes, thank you again.
Yeah.
Okay, so hopefully we'll have time once all of our speakers have had a chance to bring everybody back and have a little bit more of a conversation with all of our panelists. So thank you very much, Dr. Bach. Next up, I'm very excited to present John Costello, who's a speech-language pathologist. My background's also in speech-language pathology, so this is the one part of the conversation that I can follow every time, which I feel really good about, so thank you. So I first heard John speak at the clinical conference for ALS about 1.5 years ago, and I was floored by his expertise in augmentative communication and his dedication and compassion in working with families and making sure that everyone has a means of communicating. John hails from Boston, from Children's Hospital, Boston, correct? And so I'm going to let him take it from here. Welcome, John.
Thank you. Thank you very much. Hey, is it possible to shut down this line of lights? Just because I have a video, I think, that will run, and I think it's harder to see. It's a real pleasure to be here, first of all. Thank you. I'm curious, just because I'd like to understand who I'm sharing information with, and how many people here are family members of someone who has ALS? How many people here are living with ALS? Thank you. So it's very helpful for me to kind of better understand. As you heard in a very generous introduction, I'm a speech-language pathologist at Boston Children's, focusing in augmentative communication. And, you know, anyone who knows me and anyone who is here this morning already understands that I could talk for hours. And there's a lot of information I'd like to share. So I'm really trying to narrow down today to talk about quick access, low-tech tools. In the world of augmentative communication, you can cover the span from the most sophisticated technologies and to some really wonderful tools that are here that I hope you'll look at during break, to some really simple tools that can be useful and sometimes are really useful in the heat of the moment. My disclosure, I work at Boston Children's. The team that I work on is the ALS Augmentative Communication Program. There are 4 of us on our team, you see pictured here. We have a website, and I want to tell you, I want to make sure that you know about the website because there's a lot of information I'm going to kind of go through quickly. And there are also some templates for making materials that are on our website that are free that you can download. And so I'll put this here, and then maybe right before I finish, I'll put it back up if I say anything that you're interested in where you want to download those templates. Something that I first want to make really clear in terms of thinking about augmentative communication, and because there are so many people who are living with ALS, and I mean family members as well as individuals living with ALS here, I think it's important first to highlight that communication is not just talking. Communication is lots of things. It's email, it's texting, it's getting on the internet. And for many, many people, those are way more important than thinking about using speech-generating devices early on. And while we're not going to get into lots of that during my brief conversation here, I just think it's important for you to know when you're seeking communication support that you should be making it clear that you're looking for communication so you can continue to do everything that you do now, and that there are lots of tools and strategies available that do allow you to do that. I'm actually going to kind of go through some of that. There are lots of considerations in our protocol for folks who have ALS, and I'm just going to touch upon the quick access tools today. So, and there's my fancy footwork with my slide. I want you to hear from Holly, and this is a video if you would run, where I had been talking with Holly about the fact that so many people think that augmentative communication is just technology. And Holly's a woman with whom I had the greatest pleasure to work for nearly 3 years, and she was very focused on wanting to make sure she shared through her story with people living with ALS and their family members kind of her experience with augmentative communication. And what you're going to hear here is Holly speaking to the fact that that low-tech tools are really important. Would you run that video? Thank you.
Tech is not an answer to the intimate moments. Bed, bath, breathing. Tell the story of how quickly things changed so that there is a moment when you need all the tools.
So what Holly was really trying to highlight is that even if you've got technology and you're a great user of it, and she is a great user of technology, she was using eye tracking there, that there are all these times during the day where it just doesn't work. When you're in bed sometimes, when you're in the bathroom, when you're in the bath. There are all these other really important communication needs or times when we need to have backup tools. So what became clear to me very early on, learning from a lot of people with ALS, is that, and I think we can all relate to this, the worst time to learn to do something is in the heat of the moment when you need it. Regardless of what it is we're trying to learn. I think we can all relate to that. For a lot of the people that I work with, it has become really clear that if I'm asking them to learn to use a strategy when they need it, it's really hard. It's really hard to internalize the skill. So I kind of learned pretty quickly that if I can ask people with ALS and their family members to develop strategies collaboratively with me, if they really need to use a backup tool, they're going to be able to use it because they were the ones who created it. So I was working with this man and woman, husband and wife, and this woman, Linda, has ALS. And her husband said to me in my office, I feel like such an idiot. I said, what do you mean? He said, I was helping my wife in the washroom, and she has a rolling chair that we bring in. And she, at this time, is using some speech. And she said something to me once we're in the bathroom. And I said, what? And she said it again. And I said, what? And she said it again. And then he looked at me, and he was so mortified. And he said, and then I yelled at her and said, I don't understand. And his wife got upset that he was so upset with himself. And he said, then I said it again. As she said it again, I said, what? And a fifth time, and then he said, and John, this is why I'm an idiot. Because what she said to me was, don't forget to lock the wheels. And he said, she says that every single day at that moment. Why didn't I get it? Why did I make her repeat it? Why did I yell at her? And so often I'll say to people, write that down. Just start to write down a list of messages that you know are going to be important. Nobody does it. Nobody writes down. I'll say, put a piece of paper on the refrigerator, start to scribble things down. Nobody would do it. And so, and I don't know about you, an awful lot of people I know like structure. They like to be given sort of a recipe for this is how to do it. So what I started doing is making templates. And I think there's another one floating around here. Someone had, there, you're the culprit. That's right. Well, this template first. So I started making these blank templates that have tabs on them. And on our website, this is something that you can download. And I would say to folks, okay, and I give them the blank template. What I'd like you to do is throughout the day, as messages come up that you realize that comes up a lot and I never want you to miss it, tell someone to write it down. And on the tabs, you might decide I'm going to have one related to positioning and food and household chores and children, whatever the categories are. And just start to scribble those down and fill them in. At some point, when you think it's kind of getting full, give it to me. We're going to make them pretty. And I've got a bunch of examples, if at break you want to look at. What we're going to do is make it so that then, in the heat of the moment, if there is that situation where I want to say, what? Maybe I'm going to say what once. My next question is going to be, is it on the flip book? And you're going to know it's there because you're the one who created it. You're the one who directed the creation of it. As opposed to if I just made one for you, you're always going to be like, I think it's there, maybe, I don't know. But if you were complicit in creating it, Then what I'm going to say, if you say yes, is, okay, is it on, and in this case, and everyone has different categories. This one happens to have wheelchair, bed, front room, dressing, eating, toothbrushing. If the answer is yes, then I would flip to that page, go through the columns, get to the message, done. And, you know, a whole bunch of people, I see a bunch of people nodding and smiling because I think you kind of recognize it's such an obvious, easy tool. I would like to tell you that many people have said to me, this is brilliant. And I will take that. It's not very brilliant. It's just obvious. It's one of those practical things that you should just kind of plan in advance. That being said, and the reason I'm so passionate about sharing this information, since doing this, I've had so many people who've reported back to me that there was some moment, whether it was when someone was in bed or someone was having a spasm in their leg, or someone was concerned about something, where they were able to very quickly get to the message because it was on there. Done deal, finished. And folks who've said to me, it just sort of saved so much time and energy. And I've had a couple of people who, one person in particular, who really, because she had been so complicit in creating that flip book at a time when she was really, really medically fragile. And when she was when no one really expected her to be able to advocate for herself, she was able to, at that time where she was really fragile, vocalize to let someone know that she wanted something. Her partner was able to ask, is it on the flip book? She said yes, and was able to very quickly go through and be directed to a specific question, a specific statement. It was actually related to her positioning in her chair, where she needed to be reclined, not only for comfort, but for breathing. And she wouldn't have been able to do that had she not had that book available. So I strongly encourage everyone I work with to very early on think about creating that. Go to the website, download the template. So on our website, there's a whole description of how to use it. There's a description of, why did we create it? Typical instructions for the person who has ALS, as well as typical instructions to the communication partners. And let's face it, you can have a tool, but if everyone doesn't sort of have an agreed strategy for how you're going to use it, it can still fail. I actually have had, I think I have an example here. There's a man I work with who wrote me and said, I've got all of these care providers who are in and out of my house all the time. And so he sent me through email instructions for what he thought needed to be on the front page. And maybe I don't have it here. And his instructions, basically, I wound up repeating on our website, where he basically tells people, always ask, is it in the flip book? If I say yes, this is exactly what you do. And again, that's on the website here. There is also, and that's just an example of, and you see, we make them and then people do all sorts of things. People stick photos on there because they want someone to see this is exactly the way this should be. The setup, the positioning, so folks will put photos on there. People write in all kinds of messages. That's an example of one in process. By the way, it's never done. So if you think, okay, I'm going to do this and we're going to have it done in 2 weeks, the moment you do it, the moment you decide to sit down and type it up and make it pretty is when it will be out of date. And what I've learned from a lot of people is that, tomorrow brings something that I hadn't even anticipated needing to know and talk about. And because of that, tomorrow there may be a whole page of messages that I now want to have on there. So it's never done. And that's one of the reasons I wanted to make sure that on our website, would you play this video, please? And we won't play the whole thing, but just
if you would like to use our customizable
just kind of a tutorial for how to get into it.
Go to our ALS website.
And actually, would you skip
click
like a
on
half inch
protocol
in,
assessments
please?
and considerations. go down to the quick access. Certainly read the instructions.
Yeah, a
for the
little
person
more. I hate hearing
customized
myself blab.
flipbook. If your system gives you an option, feel free
You
to
can
make a
listen
copy.
later.
And
And
now
then
you
just
will
sort of
see
showing how
that
once you
as
get in-
scroll down, first of all, there are some general instructions on how to use this. There are some directions that you may or may not use. These directions have actually been vetted by people who have ALS, and some have wanted to have them on the front of their flipbook so partners have some instruction. Then, as you scroll down, you can see that there are multiple pages here. You would simply go to the tab, click on the tab, type in whatever topic this page is going to be. I'll put positioning here, or position.
I have control.
Then go up to the,
Maybe.
it's telling me that it's a copy. That is good. And go up to the individual targets, and you can now write in.
So
then go back and
anyway,
modify.
really you can just
So
kind of go in,
delete pages
type,
and
change the
certainly
color of the
make sure that
text,
it's always
and
meeting the authentic needs of someone
print that
or
out.
in the moment.
You know, we laminate ours. I actually have gotten to the point where we don't always laminate it because it just keeps changing. And we also want to be able to kind of write in messages. Some of the typical instructions, again, identify a situation or context throughout the day. Write each context on the tabs. As you think about predictable messages, add those in, and so on. A lot of the things that I've just said. Some of the categories, and this is just examples. And by the way, this handout, is this something that you've got to share? Okay, and if you'd like to do that, also I will make certain that it is on our clinic site as well, if you wanted to kind of go and look at it, because I know I've got a lot of text there and 7.5 minutes left. These are examples of some categories. I have to tell you, though, in fact, the asterisks here with happy words. So a few years ago, I was working with a woman where, you know, we make these and focus a lot on immediate needs. And this was a huge reminder to me about how communication and language is so big and broad. So Holly had said to me, using partner-assisted spelling, which we're going to look at very quickly, I wish we hadn't forgotten the happy words. And what I learned from her through a series of questions later is that she had all of these family members she hadn't seen for a very long time coming into her home, and she wanted to very quickly socially connect with them. She wanted to, through this strategy, be able to say, I love you. I miss you. I'm so glad you're here. And really have some statements with people that she felt were important, especially as she had family members who were coming a distance and she didn't know if she would see them again. So, you know, the categories can be anything that you want. Also, you know, so there's something else that we do a lot in our clinic, and I think you'll hear about from other people now here in Hawaii in clinics, called message banking. And message banking is kind of thinking about messages that are really important and actually recording those so that if you ever needed to use technology in the future, you could put that in. It's been interesting to me, and it was unintended. People have thought so deeply about messages to put on here that they've actually generated a script for themselves of things that they want to record. So it's informed that process. So quick access strategies. This video is a woman for whom I was introducing the idea. She writes a lot. She uses a boogie board.
What do you think the value of having a low
But she also has this low-tech board. And I was asking her, like, what do you think?
I think a combination of all is good depending on the situation.
Situation.
Situation. So what kind of situation would the low tech be helpful?
It's fast and to the point.
So Patricia has a neck brace that she chooses to take off in my office for comfort, which is why you see her supporting her neck there. But what her point is that sometimes she can just quickly, it's fast and to the point, get out important specific messages to people. One other very quick in my last 5 minutes here. So there's this strategy called partner-assisted spelling. And what I'd like you to do is think about a time when you are really fatigued. So again, this isn't something to think about because you urgently need it now. It's important to think about the what if I have spent my whole day being so active that now I am totally worn out. And I want to communicate something to someone, and it's just too hard for me to get my point across. And it's hard for me to point, and it's hard for me to write, but I want to generate a novel message. So this strategy is called partner-assisted spelling. And what it is, and I've got one here, and you've got the other, so you can hold it up. This is also a template, thank you, Vanna. This is also a template that's on our website that you can print out. So if you look at this, and again, think about being really fatigued and tired. You don't have to keep holding it, thank you. And there's something that you want to tell me. So we're going to spell it, but it's hard for you to point. So I'm going to go through the alphabet with you. But notice that the alphabet here is organized by vowels, A, E, I, O, U, Rho. It's designed that way because lots of times people very quickly can remember that organization because of the vowels. I'm now going to go through and ask you to kind of spell a key word. I just heard myself. so that was spooky. What's that? Okay. So now what I'm going to do is I'm going to move forward because I think I actually have the video in here. Actually, I'll show you this video of introducing this in clinic. This is another situation where you want to ideally learn to use it proactively. Let me demonstrate it for you. So think of, but don't tell me, a very simple word. Just for sake of our practice, a simple word. Now looking at this, I'm going to ask you, and really pretend you are so wiped out, like don't even say no if I say the right. Just wait until I get to the right area and say yes. So preserve your energy. So the first letter of your simple word, is it in the A row, the E row, the I row, the O row? Okay. Is it the letter O, P, Q, R, S? First letter is S. Now, you're, as everyone does, naturally like saying no, which is fine, but really, so you can see how this works, do nothing. If you do nothing, I'm going to keep going. Okay? So first letter is S. Second letter of the word, A row, E row, I row. Is the letter I, so S-I. Third letter of the word, A row, E, I, letter I, J, K, L, M. I'm going to let this keep going, or stop that there because it's on our website. And you can watch that on the website. There's actually a whole tutorial video that's on our website. I thought I embedded it here, but I didn't apparently. That it kind of steps you through the process. There's an example of a woman with ALS at her home in her bed really using this. And then there's a whole section, there's like 6 minutes of tips and tricks, things I've learned from a lot of people with ALS that we should do. Like many people want to make sure that if you're not able to remember where they are as you're spelling, that you're writing it down, because there is nothing worse than getting halfway through a word and then having someone forget what the last letter was that was spelled. The other reason I think it's really important to try to introduce this early is that, and in fact, I challenge everyone I work with to learn this to a point where you no longer need the card, so that it's so internalized that you can go through. So if you were to ask me, do you have a pet? And so I'm going to play both parts for a moment. So, do you have a pet? And I'm going to start to spell to tell you what kind of pet I have. A group, yes. A, B, C, D, yes. A group, E group, I group, O group, yes. O, yes. A group, E group, yes. E, F, G, yes. Did you get what I did? So I spelled out dog. There's a man and woman I work with who said to me, this is, despite having all this great technology, one of the best strategies that we've got. And he said to me, you know, we drive an hour and a half to doctor's appointments, like a lot. And my wife is in her chair in the back of the van, and I'm driving up front. And because we learned this early and we've internalized it, we now are able to have a conversation the entire time. And then he gave me this example, and then I'll stop for questions. He'll say, I'll be driving along, and my wife will will vocalize, and I'll say, do you want to spell something? A group, E group, E, F, A group, A, E, I, O, P, Q, R, S, So far we have FAS, ultimate backseat driver, A, E, going on, and what he tells me is, like, we're driving down the road, and my wife is telling me I'm driving too fast, and she's directing me using this partner-assisted spelling because it has become such an easy strategy for us. So, well, this was obviously a quick introduction to thinking about early proactive strategies that that family members, care providers, and the person with ALS are kind of complicit in creating and learning. I think that regardless of how fabulous technology is and how powerful it is, and it is, they often tend to be some of the best strategies and the most important strategies in either kind of that situation in the car or in the heat of the moment. So let me stop. Are there any questions? Wow.
Well, you know,
and the templates are on our website,
Yeah.
so you could download those, and the top in blue is the website.
so I will say, though, that I want to remember back on when I went to the clinical conference, and I'll share with the team here. One of John's, John is known for really promoting early use of these tools and early voice banking, about how whatever you put on these little things that we have here, right, is your menu of what's going to be on your message banking for later on. And probably one of the most moving videos I've seen of yours, which is on your website, you were teaching someone how to use their eye gaze device for the first time, and they had done this message banking. They had taken your advice and they had done this message banking, and the woman was really very hesitant to use her eye gaze device. And you didn't even know it at the time you were shooting the video that her dog, do you remember this video? The dog was sitting by the wheelchair, and the dog had not heard this woman's voice in quite some time. And the very first time she used this device with you, I think it was to call her dog or something?
Well, she used the device. She was actually testing to make sure that everything was working.
Yeah.
And we didn't realize her dog was in the room. Do you still have that video?
Since we have a minute.
Since we have a minute, if you could pull it up. And you will see, so Holly, and actually I'm glad that we get to show this because Holly is someone I mentioned earlier, really wanted to be part of making sure she taught as many people with ALS and their families about communication and the importance of communication. So you met Holly a bit ago talking about why low tech was so important. It's right after message banking.
And while that's
it's the third
queuing up, I also want to let you know that John presented a few tools today, and also Taryn, your care manager, she also has a whole kit of low-tech devices, voice amplifiers, switches, these types of things that can be used for a number of different things. So we touched on some today,
Yes.
and this is really just grazing the surface.
Absolutely.
But very nicely, thank you so much. And if you're interested in having some of these demonstrations as well, Taryn can show you these additional devices as well. There was a question?
Oh, no, ma'am, just a quick comment. Oh, thank you. Just a quick comment. In the dark ages of ALS in the 1980s, when my husband was diagnosed, he had to create one of these for himself. And we just called it the alphabet board. And instead of A, E, I, O, we just said 1, 2, 3, line 1, line 2, line 3, line 4, and so on. And I'm just so smiling in my corner here to think that now at least I said, oh, there's a name for that. Now it's called partner assisted spelling.
And you can download the template too, right? Right. Okay, so I'll get out of your way here.
Well, and I really wish that we'd been able to kind of cover lots more information, but on the website there are a lot of resources, including lots of resources for voice amplifiers, many other low-tech tools, and since you mentioned message banking, so the very quick story is Holly had thought lots in advance about messages to bank, to record. Then we incorporated those into technology. And the goal with message banking is to capture messages that are really important to you, that represent who you are and how you relate to the people around you. And so she was just kind of testing out now to see, is everything working? And I happened to have my video camera set up since it was an operational test, and this is what happened.
Walker, come here, Walker. Walker, come on. Walker, come here, Walker.
Isn't that great?
Walker, come on. You want a cookie?
Awesome! That's awesome! He got a hold of something.
Where's that silly dog? Walker, come here, Walker.
And Walker hadn't heard
Walker,
Holly
come on,
speak
you want a
in almost
cookie?
2 months at this point.
Where's that silly dog?
And this video is on our website if you want to watch it, and there are many more as well.
Thank you so much,
Thank you.
Sean.
Sure.
Thank you.
Thanks.
Yes, Cookie.
I just wanted to share something because my husband had bulbar palsy, so he lost his voice very early on, but he still had some mobility. And while it does require tech, he either had his iPhone or an iPad, and he downloaded this app called Magic Slate, and it's kind of like an Etch-a-Sketch, so he could write and communicate easily with, not whole sentences, but little phrases and little words, and he could do it really pretty readily. So I had seen him converse with my 5-year-old grandniece, talking about her excursion. She's talking to him, and he's like writing, and so,
And there's for people who don't have for people who don't have phones or tablets, there is a tool called the Boogie Board. And I'll bet you've got it in your yes. That does the same thing as an even lower tech option, but very powerful. And I always joke with people that since you can sort of write and then press the button and delete, unlike writing everything out on a pad of paper where that pad stays around forever, you can write something and then destroy the evidence by deleting it. So.
We have them. Yeah, we have them. If you need them, let us know. Let Taryn know, and we'll get you a Boogie Board. Okay. So thank you, John. Okay. Next up, we're covering a lot of different ground this afternoon. And next up, we have Dr. Mark Bromberg from University of Utah, a neurologist there, who is here to cover a broad spectrum of issues, conversations to have with your neurologist. I forget what our exact title was of this particular presentation. What did we decide on? Because we decided it yesterday afternoon, didn't we?
Potential treatments and cures.
There you go. Potential treatments and cures. So, yes? We're changing something. So we're going to have a minor technical pause, a minor technical pause, and welcome Dr. Bromberg.
Thank you.
Tell us a joke. Cookie, you can sing us a Hawaiian song. We've had, appreciate everyone's patience with our technical difficulties today. These guys are great. These guys have been awesome.
Oh, it's amazing.
I get time credit back. Keeping track. Okay, well, I'm very pleased to be here, and so I would like to make this very open, and I have a number of topics, and I'll just tell you briefly what they are, and I want to cover as many of them as possible. And so I want to talk about research, trials, and treatments. And so I'm going to kind of monitor my time and try to cover these. So let me just talk a bit about research. So research can involve quite a bit of territory. We have so-called bench research, and that's what leads to a better understanding of what we think causes ALS, and I've got plural because there may not be a single cause for ALS. And it also leads to data that would suggest a treatment trial, and we'll get to the treatment trials at the end. Part of that process, so-called bench research, would be dealing with cells in petri dishes and cultures and things like that. Ultimately, it goes to animal models. There's no natural model of ALS in animals. You can make an animal model by taking some components of the genetic form of ALS and putting that into an animal. It doesn't reproduce clinical human ALS, but it does gives you a tool for you to look at the animal at various stages and things like that. And then there is clinical research that doesn't involve medications to slow the progression of ALS. For example, you could have interventions, and we heard about from John Bach about respiratory support. You can prolong survival. If someone in the old days needed a tracheostomy or elected not to have a tracheostomy, they would pass away. But with non-invasive ventilation, it can be used 24 hours a day, and so you can extend the natural course of ALS for that particular person, even to an indefinite period of time, measured in years. We had a lecture yesterday about nutrition. We feel that supplementing nutrition when a person becomes losing weight and things like that, that supplementing nutrition can prolong survival. Then there are a lot of symptoms associated with ALS. So it's a consequence of ALS. Excess saliva, emotional lability, muscle cramps, fasciculations. Many of those things we have some treatments for. But a lot of the treatments are taken from other disorders. We haven't really tried those treatments in ALS specifically. So empirically, we have some evidence that they're effective. But you could have a treatment trial. For example, there was one, cramps in ALS using mixilotine. And then there's the quality of life. And so quality of life is very important. And there are a lot of quality of life instruments that can be used to assess a patient's quality of life. And the answers that you get depends upon the instruments that you use. And I think that if you use more open instruments, that is not an instrument of quality of life where function is a component. So most of these instruments have what they call domains. They can have a social domain, a personal domain. They can have a functional domain, that is strength in doing things. If you have a quality of life instrument that has a functional domain, in ALS, function will change. It will go down over time. So all of those quality of life instruments will be driven by, that is, the scores will come down if for nothing else that a patient loses function. So I don't think those instruments give a good picture of the quality of life in ALS. If you use an instrument where the patient assigns their quality of life, what it means to them, it turns out that for most of the time course of ALS, patients rate their quality of life as being quite good and unchanging, even if the rate of progression is such that they lose more and more function. And then we have the caregivers. So we're talking a lot about ALS patients, but keep in mind this is a 50-50 team here. And so we need to look at the caregiver burden. As a patient becomes weaker, the caregiver has to give more and more time and gives up their time. And so there are clinical research projects where you're looking at caregiver burden and what one might be able to do to reduce caregiver burden. And then there's research in underlying mechanisms and part as it relates to genetics. And there are a lot of people who feel that genetics is a major factor in ALS. In some people, it's a clear, unequivocal factor, meaning that in the family there are other people with ALS. And it's a genetic disorder, and if you have that gene, inherit that gene, if you live long enough, you will get the symptoms of ALS. There are other more subtle factors where the genetics may be not mandatory that you get the disorder if you live long enough, but it's a risk factor for that. So that's a spectrum of research. Now let me talk about drug trials, because this will go into the next section. So these are drug trials more to try to to extend the length of ALS. It's unlikely, unrealistic for a patient to have any kind of a trial that will restore strength. Because once a nerve cell is lost for any reason, whether it's a stroke or brain trauma, or in this case, loss of motor neurons, we're not going to be able to put them back into the brain. So we're really looking realistically for a drug that will slow the rate of progression. Obviously, we'd like a drug to stop the rate of progression. But again, realistically, we're looking for at least a slowing in the rate of progression. So we do not know what causes ALS. There are many, many theories out there. And I don't want you to think that there's only one theory. And if you have one theory, it doesn't exclude all the others. ALS may represent a cascade of changes that occur in the cell. Because whether you've got genetic-based ALS or sporadic-based ALS, for a room full of patients with ALS, you can examine all of them, but you can't tell which ones have familial ALS. In other words, it all basically has the same set of clinical features. So that suggests that there's a final common pathway, that you could start with a genetic cause, and there are over 20 different genes that have been identified. So when I say a genetic cause, it may not be one pathway within cells. There may be 20 different pathways, but they begin to converge. The same way with sporadic ALS, it all converges to the same thing. So despite the fact that we do not have a full understanding of what causes ALS, it hasn't prevented people from coming up with a particular theory, finding a medication they think would work at that step, and then testing it in ALS patients. In the last 25 years or so, there have been well over 100 compounds that have been tested for ALS. Unfortunately, most of them have not been successful in showing a slowing in the rate of progression. There are two, however, that have been, and I'll get to that. One of them is Riluzole, and the other one is on patent, so it's got two names. The brand name is Radicava, and the generic name is Edaravone. So we do have two out of these 100-plus tests that have shown some statistically significant change in the rate of progression of ALS, those taking those medications compared to placebo. So how do you get there? Someone has an idea, they do some basic science, it seems to work on the pathway that they think is involved. They may try it out in animal models and show that those animals that get the drug seem to do better than those that don't get the drug. And then they decide to have a human trial. Now, in this country, for a human trial, it has to go through the Food and Drug Administration. And there are basically three phases to a drug trial. The first phase, or phase one, is you try the drug on a very small number of people, and usually they're people with the disorder. They could be unaffected volunteers, just to see if the medication is safe. Because the Food and Drug Administration has two major goals in these trials. One is the drug that you're giving, is it safe to the individual? And number two, is it effective? So safety comes first. So in a phase 1 trial, there may only be a few people who get the drug. And if it proves to be not harmful, then the FDA allows you to go on to a phase 2 trial. In a phase 2 trial, you may have another group of people, maybe 2 or 3 or 4 times as many, maybe up to 50 or 100 people. In a phase 2 trial, you know at least the basic dose is not toxic, so you can increase the dose and find out what's the maximum tolerated dose. Then you can also figure out sample size, how many people would you need to get to a phase 3 trial. And then you can figure out what endpoint measures you're going to have. Because every trial has to have an endpoint measure. There's a primary endpoint measure that the trial is going to stand on. Did the trial meet the primary endpoint measure? And then you can have secondary endpoint measures that can be supplemental. So if you get through a phase 2 trial, and you show that the particular dose you want to use is not harmful for the patient, and you've worked out your statistical sample size and so on, then you can go on to a phase 3 trial. Phase 3 trials are also called pivotal trials. The pivotal trial means it's the trial that will determine whether the FDA will likely approve the drug or not. Now, pivotal trials can have hundreds of people in it. Again, you have a sample size. And some pivotal trials will have 400 ALS patients. They also cost in the tens of millions of dollars. So you have to have a sponsor. Sometimes the NIH will sponsor a trial if you put in a grant, and they feel that you've got enough evidence to support the likelihood of the trial being successful, or it's an industry-sponsored trial. So a pharmaceutical company comes up with a drug, they get through phase 2, they think there's a high probability that it will be successful, so they put the time and the money into it. If you want to have a trial with 400 people, there's no single clinic that's going to get 400 people in a reasonable amount of time. So these are called multi-center trials. So there may be multiple centers in the country, each center contributing a number of patients, so that over a reasonable amount of time you can enroll all these 300 or 400 patients or subjects. Then the trial has to last a certain length of time. The longer the trial lasts, the more solid the information is, but it takes a long time and it costs more money. The shorter the trial is, the less expensive, the less time it takes, but the variability in ALS is such that it becomes a challenge to get a clear answer. So there's a trade-off there. But a trial will not end until the last person has completed the trial. What are trial lengths? Well, 6 months is short, and a year to a year and a half is long. So they're usually between 6 and 12 months. But you have to enroll 400 patients. The last one has to go the 6 months, and the data have to be analyzed. So a phase 3 trial is going to take 3 or 4 years to come to completion. So now we're looking from phase animal research to the end of a phase 3 trial of about 4 or 5 or 6 years. So it's a long process. Then there's trial design. So most trials are placebo-controlled, which means that when a subject goes into a trial, they are randomized to either active drug or placebo. And many patients say, I don't want to be on a placebo. It may not be effective. Going into a trial, there's a concept called equipoise. In other words, you've got some data that the medication may be effective, but maybe it's not. And so it's kind of like a seesaw. It could go either way, equally effective and ineffective. And so when I've told you there are over 100 trials, each one's gone in for equipoise, but you can see that there was no real sure bet going into it, because unfortunately most of them were not successful. So as a person who participates in trials, I feel comfortable telling the patient, we really don't know. It's 50-50. So being on a placebo is not necessarily a bad thing. And in fact, some of the unsuccessful trials, the placebo arm did a little bit better than the active arm. Sometimes the randomization is 1-to-1, sometimes it's 2 for the drug and 1 for the placebo and things of that sort. Okay, so we talked a little bit about interventions that are not drug, but respiratory support, nutritional support. We talked about some treatment trials, not to shorten or to extend the life of the disorder, but to treat symptoms. Problem with symptom management is most of these medications are used for other indications, but now you're applying them to ALS. And most of those drugs are off patent, and it's hard to get sponsorship to pay for those trials. So there are relatively few trials for symptomatic management. So now we're coming down to disease modifying drugs. For the expectations, I said the expectation is, or the hope is, that the drug will slow the rate of progression. So a challenge in these trials is if the person is going to continue to progress, how do you know that you're actually slowing the rate of progression? So you need to have an endpoint measure that's going to be sensitive to that. I'm going to come back to the treatments on the internet in a moment. So let's go to the expectations. Now I'm going to jump ahead to the Riluzole trial. So Riluzole was the first drug that was approved by the FDA for efficacy in ALS. And so what was the theory behind Riluzole? As I said, there are a number of different theories. One is that the neurotransmitter between nerves. So when nerves are talking to each other, it's not that one nerve touches the second nerve and conveys the signal. When the impulse gets to the end of the first nerve, it causes a release of a chemical called a neurotransmitter. That neurotransmitter goes across a microscopic space, interacts with the second nerve, and starts the potential to go down that nerve. So it's a very complicated process, but by the fact that I'm standing up here and talking, this is happening hundreds and hundreds of thousands of times a second, nerves talking to other nerves. So basically it's very reliable. Now, there are different neurotransmitters in different brain systems. For the nerves we're talking about in ALS, the neurotransmitter is glutamate. So the theory behind Riluzole was that there may be an excess of glutamate, a relative excess. So the medication, Riluzole, reduced the amount of glutamate that comes out, enough to cause the transmission, but not an excess, because an excess could cause neurotoxicity of the nerve cells. So that's the underlying theory. Now, this was approved in 1995, which meant that in the 1990s, we had a different endpoint measure. Since ALS is a progressive disorder and unfortunately leading to death in everybody, the endpoint measure was survival, or tracheal-free, reaching a point where you needed to have a tracheostomy. So what they did is they took a bunch of people, they divided them up, 50% got the medication, 50% got the placebo, and they looked at survival a long time, 0 out here to 18 months, and here's 100% survival, and at the end of 18 months, they broke the code, and so the dark line here are the people taking Riluzole, and the light line are the people taking placebo. And at 12 months, you can see that there were fewer people who had survived on the placebo compared to people who were on Riluzole. And that survival advantage was 0.11. That doesn't mean a whole lot. But if you extrapolate that, if you say that the people who were on the active drug at 12 months had a survival advantage of about 3 to 4 months compared to those on placebo. So that was sort of the point of Riluzole. It extended survival by extrapolation 3 or 4 months. Now that's not a lot of time, but that was the only medication that's been shown to have any effect on survival in ALS. Now since the 1990s, We've got non-invasive ventilation that Dr. Bach talked about. So the idea of tracheal-free ventilation had less meaning because we have an intervention. So that has changed the endpoint measure that we have. Another point with Riluzole is it was statistically significant at 12 months, but it was not significant at the end of the trial at 18 months. So an open question is, if it helps at 12 and it doesn't help at 18, should we continue the medication after 12 months? Now we go to Edaravone. So this was approved just last year. So now we use something called the ALS Functional Rating Scale. So ALS starts focally in basically everybody. In about a third of the people, it starts with weakness of speech and swallowing, so-called bulbar onset. In a third of patients, it starts with weakness in arms, fine motor control. In a third of patients, it starts with weakness in the legs, difficulty walking. So the people came up with a global functional rating scale that assessed function for bulbar, assessed function for fine motor control, assessed function for walking, and assessed function for breathing. And so it's called the ALS Functional Rating Scale Revised. And so if you have full function, you get maximum points, and so 48 points would be normal function. And the scale is important because you will lose points if you have bulbar dysfunction, even though you've got normal arm and leg function, or you'll lose points if you have weakness in the legs but normal arm and leg function. So you can look at different domains. So there were two Edaravone trials. First of all, Edaravone was a drug that was developed to treat people with stroke. The underlying process or theory for that was that it reduced free radical damage. All of our cells produce toxic molecules that are in an energetically unfavorable state. So to make themselves energetically favorable, they start pulling bits and pieces off of other molecules, in turn causing them to be unstable. Now, normally this happens to all of us, but we've got other molecules in there that neutralize this. So the idea in a stroke is you've upset this balance, and so if you can reduce free radical damage, you may reduce some of the damage of stroke. Free radical damage has been one of the theories in ALS. So I guess the folks who made the drug thought, well, let's try this also in ALS. They had a number of small trials, phase 1 and phase 2 trials. It seemed to be the drug was safe in ALS and it might have had an effect. So they went on to a phase 3 pivotal trial. And they chose what I would call an average group of ALS patients. They divided them up. Half got the placebo, half got Edaravone. This trial used the ALS Functional Rating Scale, and they went out 6 months. At the end of 6 months, when they broke the code, it turns out there was no difference. Edaravone had no effect on this group of patients. But then they did something called post-hoc analysis. In other words, the trial was a failure. But they went back into the data and to see, was there a subgroup of patients in this trial who seemed to benefit from the Edaravone? And they thought that they could identify a subgroup. How did they identify a subgroup? They did it by looking at the ALS Functional Rating Scale. And they found that maybe the first trial wasn't effective because everybody was moving too slowly. They, by chance alone, got a group of ALS patients, both placebo and active when they divided them up, that had a very slow rate of progression. So they chose a group of patients who had loss of function in bulbar a little bit, loss of function in arms, loss of function in legs, and loss of function in breathing. So all the major domains had some degree of involvement. So they did a second phase 3 trial. They enrolled only those patients that had lost things across the whole spectrum. They followed them for 6 months, and here are the data. Here's the ALS FRS rating scale, and you can see at 48 is here, down to 0. They had a lead-in period where they just followed patients before they gave them medication to make sure that they were going along at a uniform rate. And then here, at time 0 out to 6 months, they randomly divided them in one group who got the drug and one group who got placebo. And at the end of 6 months, they looked here. The red line here are those that got the edaravone. The blue line are those that got the placebo. And the difference between them at the end of 6 months was about a 33% difference. In other words, those that got the edaravone lost points, lost function on the ALS-FRS score 33% less than the people on the placebo. And that was statistically significant. Another way of looking at it is that the people on edaravone at 6 months had a functional rating scale on average that was equal to the placebo group at 4 months. So if you want a time element in there, in addition to the 33% slowing, you can say there was a 2-month sort of extra period there, at least functional. Now, this trial only went out to 6 months, so we don't know what happens at 12 months or beyond that. There was an extension phase going out a second 6 months, but there was no placebo control for that. So we do know that the edaravone group, as it went out another 6 months, seemed to have the same curve there, or the line there, the red one, but we don't have a comparison for the placebo. This was enough for the Food and Drug Administration to approve edaravone for, quote, ALS. Even though the trial focused on a subgroup of patients, the FDA did not restrict it to the subgroup of patients. So here we have a bit of a challenge that I have to say I do not have a clear answer, because the edaravone trial only works for a subgroup of patients, but if you have a group of patients with ALS, you need to ethically give them the choice. Here is a drug, and it's approved for your condition, and I don't see it's sort of ethical to say, you have this score, you can take the drug, you have this score, you can't take the drug. So that's how I feel about it. There are 2 drugs that are available. They should be open to everybody. Incidentally, 95% of the patients in this trial were also taking riluzole. So we don't know if it works better or less well with or without riluzole, because 95 and 5, you just don't have enough subjects to look to see if there's a difference between them. Now, there's some practical aspects. Riluzole is very easy to take. It's 1 pill, you take it 2 times a day, and essentially no side effects. When you look on web pages where patients look, they'll come and say, well, there are all sorts of side effects. But in my experience, using this for 20-plus years, I've only taken probably 1 patient off of it because of side effects. So I think riluzole is very straightforward. Edaravone is relatively new. It does have a fair number of side effects, but I think they're manageable. And I don't think so far very many people have been taken off of edaravone because of side effects. Keep in mind, it's only been practically available since about August or September of last year. So I think there are 1,800 people in the country now on edaravone, and so far I think it's well tolerated. The other aspect of edaravone is it's given intravenously, not by pill, intravenously. And it has a relatively aggressive dosing schedule. There's a so-called loading dose, and then there are monthly maintenance doses. The loading doses is 14 consecutive days of an IV infusion. And the infusion takes an hour. The subsequent monthly doses are 2 5-day of infusion. So basically Monday through Friday, the weekend off, Monday through Friday, 2 weeks off. Monday through Friday, the weekend off, Monday through Friday, 2 weeks off. So it's a fair amount of effort on the part of the patient to have the drug infused, and on part of the caregivers and the family to either get them to an infusion center, and the people who make edaravone have sorted out lots of infusion centers are willing to give this, and then there's the issue of getting an IV many, many times. Now, apparently, in where the drug was developed in Japan, almost everybody got an IV put in. And you can keep an IV in for a couple of days, but it meant many venipunctures to start an IV. So apparently for all the people in the trial, they all got it by peripheral access. In this country, it's possible to get a so-called central line, where you get a catheter placed into a large vessel and it shows up under the skin as a port. So instead of having to find a vein every time, you've got this port and you can put a needle into a little synthetic diaphragm and inject it directly. So that simplifies it. It also means that it could be given in the home. You could train a caregiver to inject it, and you don't have to take the time to drive to the infusion center and then drive back. So I think a fair number of people are getting the medication via the port and home infusion. Some of that depends upon insurance, because another aspect of the edaravone is that it's quite expensive. The total of cost of it for a year's set of infusions is about $140,000. Riluzole nowadays is generic, and so it's about $200 or $300 a month. So $100,000 a month versus a couple of $100 a month. So far, I think insurance companies are covering the edaravone. I don't know of too many people who have been refused because the insurance doesn't cover it. And Medicare covers it, the Veterans Administration covers it. Medicare may or may not cover the central line and home infusion part of it, depending upon what kind of Medicare coverage one has. So at this point, we do now have 2 drugs that can show some efficacy on slowing the rate of progression. Another key issue is the patient going to appreciate a slowing in the rate of progression? Now, there was a survey sent out a number of years ago to ALS specialists, that is neurologists who specialize in ALS, asking them, what do you think would be a meaningful slowing in the rate of progression for ALS based on the functional rating scale? And the consensus was about a 20% change. So if you could slow the rate of progression by 20%, a patient may appreciate that. I don't mean intellectually, but may appreciate that they're really or progressing at a slower rate. So the folks who make edaravone point out this is a 33% difference, greater than the 20% difference. One problem was when they did the trial at the end, they didn't ask the subjects, do you think that you progressed at a slower rate? So it's easy for me as an ALS specialist to tell you what you should be appreciating as being slower, but I don't have the answer from the patient side, which is the key answer that counts here. So is 33% meaningful? Is 20% meaningful? I don't know. So I have to say that if you do take one of these drugs, you may not appreciate that you're really slowing because you're going to continue to progress. But at least statistically, you should have some confidence that it is an effective drug, at least for riluzole. Now, for the average patient going into the edaravone trial, it's hard to know if the drug is effective. But again, ethically, I feel I need to introduce these 2 medications to you, tell you what I know about them, and let you make the decision. And if insurance is willing to go along with it, then that would be the answer for you. Now let me back up a minute. So there are other treatments on the internet. If you go on the internet and put in ALS and treatment, you'll get many, many entries. These are ones that have not gone through the FDA, and so there is no real rigor to know if they are effective. It's what the internet says. And some of them are minimal cost and simple things, vitamins, and some of them can be high cost. One of them would be stem cells. So incidentally, I want you to appreciate that if you have stem cell therapy, it's not designed to put nerve cells back in that have died. You can't do that. So stem cells, again, are designed to slow the rate of progression. There are FDA stem cell trials that go through this phase 1, phase 2, and phase 3, and all the stem cell trial now through the FDA are at phase 2 and just moving on to phase 3. But all the other things on the internet, there is no demonstration that they are effective. Then I have what I call peer pressure there, and that is sometimes friends and family members will say, you know, I looked on the internet and you should try treatment X. And then you feel obliged to do that. If you want to do that, that's okay. Just know that there is no proof that those treatments are effective, and there may be a fair out-of-pocket expense to you. But sometimes you feel the pressure that, geez, I got to do this because my relative, my friend told me to do this, and they know it's going to work. So do keep in mind there is that kind of pressure. There is a group of neurologists headed by someone named Richard Bedlack at Duke University, and he's open to any of these things that are on the internet. So I'm part of that group, and we would love to have something that's natural that would slow the rate of progression. So when these topics, when these kinds of treatments come up, we collectively try to get as much evidence as we can. Look at the internet site, look at all the literature they mention, if any, contact the person behind the web page. If they're patient testimonials, try to get access to those patients, try to get as much information, even theoretical information, and it's written up, and anybody can get those. And so it's under alsuntangled.com, and there are over 40 different treatments that have been reviewed. There are new ones coming out all the time, about 2 or 3 or 4 per year. And so that is an attempt at objective evidence or objective data for these FDA-approved treatments that are listed on the internet. And so the final part is that even though we're looking for therapies to effectively slow the rate of progression, one treatment management option which we think has been effective has been the Als Multidisciplinary Clinics. And so we think that patients who are being cared for in this day and age are living longer just because of the multidisciplinary care clinics, which cover a broad spectrum of things like respiratory function, nutrition, and things like that, compared to patients who were being followed 2 or 3 decades ago where there were no multidisciplinary ALS clinics. So I have a little bit of time left, and so I want to open this to questions. I've got free time. Geez, I can give it up to anybody. Dr. Bach, will you want to get 3 minutes of mine? I'll sell it to you. Yeah. I think it's someone else to talk, but. Yes. Yes. How about the brainstorm stem cell? Okay, so the question is about brainstorm stem cells. So brainstorm is a brand name. It came from Israel, and it was trials there, and now it's come to this country. I think there are 3 or 4 centers. There's Mayo Clinic Rochester, I think UMass, MGH, and there may be another one. And so there are different kinds of stem cells. And so this is one where I think they took, I forgot what it was, bone marrow or fat, and they extract stem cells and they differentiate them into, these are, I forgot whether these are nerve cells or glial cells. But as I said, you're not in a stem cell trying to put a nerve cell back in. What you're trying to do is to get a cell that's going to be programmed to secrete something called neurotrophic growth factors. Neurotrophic growth factors are molecules that we all have that are sort of upregulated, turned on, genes are turned on to make them during our development. And they help attract nerves to go out to targets as we're developing as a fetus. Once we've gotten all the nerves to the targets, these genes turn off and they don't make much of the nerve growth factors. One idea is that if you have brain injury, then these genes get turned back on to a certain degree. The second point is that if you take the nerve growth factors and have nerve cells in a petri dish and pour the nerve growth factors on them, they get luxuriant outgrowth. So the idea is that nerve growth factors could help a sick neuron. Now, we've tried nerve growth factors in the past, and they were given subcutaneously. And it turns out they were not effective in multiple trials. So the theory behind these kinds of stem cell trials is you're going to put the nerve growth factors and get them in, not in subcutaneous circulation to get to brain cells, but you're going to put them very close to there. So Brainstorm gets these stem cells and puts them into spinal fluid. So you do a spinal tap and you inject them in there. And so they're circulating around in the spinal fluid, which is quite close to the spinal cord and the brain. There's another kind of stem cell, a different line, embryonic stem cells. That brand name is Neuralstem. And what they decided to do was to inject the stem cells directly into the spinal cord. So that's a surgical procedure, and they inject them in there, trying to get them actually right where you want them. So this is an example of two different kinds of stem cells, two different kinds of delivery. Obviously, the intrathecal, the spinal fluid, is much more simple a procedure. So as far as the results are concerned, they seem to be safe, and I don't know too much about efficacy at this point. They are moving on, I think, to a phase 2 or to a phase 2B into a phase 3 trial. And so, again, it will be looking for a slowing in the rate of progression. Obviously, if you think intravenous was complicated, spinal tap is a little bit about the same, probably fewer infusions. So it's another option to deliver a particular kind of medication to slow the rate of progression, but I don't have any more information about efficacy at this point.
Yeah, but again, Mark, for patients with SMA type 1, allogeneic mesenchymal stem cells actually made them stronger when they had previously been getting weaker. So,
well, SMA is a different
Right.
yeah. So it's different in many, many different ways. So you are correct about that.
Question?
Yes.
Hi, we have a question from the internet.
Oh, yes.
How can we, as the ALS community, help to bring more research to Hawaii?
Bring us over. Well, what I would like would be the centers here to become part of a multidisciplinary clinical trial network. What's happened is there are two basic organizations. One is called Western ALS Consortium, or WALS, and the other one is Northeast ALS Consortium, or NEALS. And the West and the East, or the Northeast, has been blurred. And so any center can join this. And the idea is that if you have a drug that you want to test, I said it takes multiple centers. So if you have a center that gains experience with a drug trial and the drug comes out, that center has a chance of participating in the trial. So I would urge, if you haven't already, become part of WALS or NEALS or both. And so when a drug trial comes up, you sort of raise your hands, sort of, and try to get involved. But it is important to have sort of different ethnic groups involved. And so spreading out trials, you don't want to have one center like the MGH who's got, or Hopkins or something, have 90% of the people in the trial, because you don't get a whole spectrum. So I would welcome people in Hawaii who have one ethnic distribution, which is different than other parts of the country, to participate in these.
Any more questions? Thank you so much. Thank you. And what a great segue to that last question. What a great segue to our next speaker, which is a way for anyone who has a diagnosis of ALS to be engaged with research. Dr. Paul Mehta from the Center for Disease Control will be talking about the ALS Registry, which is a way for anyone to be involved with research.
Absolutely,
Thank you so
absolutely.
much.
Thank you, Pamela. First of all, I want to thank the organizers for the invitation. Myself and Dr. Horton are very pleased to be here, and it's very, very humbling to be here as well. You guys have a great team here, so certainly it's one of those, chances to come here, talk about the registry, give you guys more information about it. No disclosures. I have a quick video I want you guys to look at, and I have another video at the end of my presentation, which is a patient testimonial video.
ALS research counts on you. For progress in ALS research, we need your help. You can help by sharing your data with the National ALS Registry. The National ALS Registry is the only research project of its kind. Data from the registry will be used to help us better understand risk factors for ALS. If more people with ALS join the registry, we can add to that knowledge. We're gathering information to help us learn what may cause ALS. Your data will be used to identify people in the U.S. with ALS, learn more about the characteristics of those with ALS, and better understand risk factors for ALS. How can you make a difference? You can take part by safely and securely sharing your information and taking the risk factor surveys. Finding out what may increase the risk of getting ALS could help guide research into the treatment and prevention of ALS. Patients can also use the registry to connect to other research studies and clinical trials. Turn ALS research into ALS progress. Learning more about people with ALS is critical to defeating it. Learn more about the National ALS Registry. Visit cdc.gov/ALS for more information.
Great, thank you. Go back very quickly. So when I start these talks with patients, I like to say there are more unknowns than knowns about ALS. So the registry by itself was created by Congress. And what it does is it allows us to figure out what causes this disease, who gets it, and so forth. This right here is a very brief slide I present typically for providers and physicians, but it kind of tells you an overview of how we go ahead and do case ascertainment. We're a registry, so we also, as in terms of look at cases in the of ALS in the U.S. So the registry is built up, or is made up of national admin databases. So we get our cases from Medicare, Medicaid, as well as the VH system, Veterans Health Administration, as well as the Veterans Benefits Administration. We also have the web portal as well, where patients can come in and go ahead and take a series of questions and go ahead and be entered into the registry. So the web portal is very important for patients because this is where we want to go ahead and encourage patients to go ahead and join and go ahead and take the risk factor surveys, learn more about what we do, as well as get information about clinical trials, Epi Studies, as well as join the National ALS Biorepository, where you can also participate in research as well. So, like I said, we do a lot more than just count ALS cases. It's very important. So we work with other partner organizations, such as the ALS Association, as well as MDA, as well as other groups such as Les Turner. We also do the epidemiology part of ALS, like I mentioned, who gets disease, the prevalence, number of cases at a specific time, mortality, and so forth. We also look at survey data, which I'll be mentioning, and currently we have 17 surveys. We also have the research notification system. This allows patients to get information about clinical trials and Epi Studies. And more importantly, we also fund research and looking at the risk factors for ALS, etiology, possible causes for ALS, and the National ALS Biorepository, which allows patients to go ahead and participate and be part of research. So right now we are working on our third report, which will be published very soon. But the second report talks about exactly who gets ALS. Currently, there are about 16,000 cases of ALS in the United States, or 5 per 100,000 cases. So right now we know ALS is more common in whites, males, and persons between the ages of 60 and 69. We are not sure why ALS affects this group so much more than other groups. That's why we want to go ahead and solve the mysteries behind ALS. Our third report will be coming out actually next week. And at that point, we'll go ahead and release the figures for 2014. This covers only 2013 right here. And you may ask, well, how come, today's 2018, how come you're not, telling us about what the number of cases in the U.S. are for 2017? Well, the premise behind this is we get these data from Medicare and Medicaid in about 3 years behind. So it's kind of like an arrear system. And so once we get the data, we'll go ahead and get it analyzed. So it's not readily available to us in real time. It takes about 2 or 3 years for the data to go ahead and catch up before we get it. These are the risk factor surveys that patients can take when they actually join the registry. So it's really important just to kind of, have patients be counted and also, take these surveys. These surveys tell us a lot about ALS. So for example, demographics, occupational history, where did you work? Military history, were you in the military? Smoking, physical activity. We also have one called disease progression, which is an ALS-FRS survey. This actually is a longitudinal survey, meaning to say patients can take it when they first join, and every 6 months we'll go ahead and send them an email, ask them to go ahead and take the survey so we can kind of gauge their progress. We also have one called an open-ended survey, which allows patients to tell us what they feel may have caused their disease. We also have surveys regarding where they lived, were they ever exposed to pesticides, their caffeine consumption, as well as, for example, head and neck injuries. Were they ever involved in, let's say, a traumatic brain injury or a TBI? So the research notification system, this right here is a really important part of the registry, and allows us to work with pharma as well as academia to go ahead and connect patients to clinical trials and research. And so this right here, currently when a patient comes in, joins the registry, they can go ahead and select a button and simply say, I want more information on clinical trials and studies. And this we'll go ahead and automatically send them information on clinical trials which they may be eligible for. Currently we have 35 institutions, so we have over 30 institutions have actually used this particular mechanism. So this is actually some of the highlighted notifications that have actually gone out. Some of our speakers mentioned some of the clinical trials which are currently ongoing. So for Cytokinetics, we actually helped them with the tirasemtiv Arrest ALS, and last month we helped them with their brand new study called Fortitude ALS. Flex Pharma is also another one we actually helped out with, FLX 787. We also helped out with NP001, which is Neuraltis' new study. So when a patient comes in, joins the registry, they will get an email in their inbox simply saying, hey, there's a new clinical trial or a notification. Please go ahead and contact them to see if you're eligible to go ahead and participate in this clinical trial. We also have Epi Studies, so these are non-clinical trials, which gives researchers more information about ALS. So for example, we have one from the ALS Association, Lucy Bruin, who's the chief scientist, and this particular survey, it's a patient trend survey or a patient input survey telling the ALS Association different ways as in terms of like possibly or avenues to pursue when it comes to research in the future. We also have a survey through Columbia University, which is looking at oxidative stress and how that potentially correlates with ALS. We also have a survey through Mass General Hospital looking at the microbiome or the actual gut bacteria and seeing how that potentially works with ALS regarding development of disease. And we also have one for ALS testing at home, which allows patients to go ahead and take the survey in the comfort of their home as well. So research is very, very important to us when it comes to getting these data in as well as getting the results out. So we actually do quite a few publications per year, and all these publications are available on our website for free. In the world of academia, unfortunately, there's a paywall, but we actually go ahead and pay the journal to go ahead and release this particular publication for open access, so you can actually read the full article. So you can go to our website, look at the articles which we've actually published, or we've helped to publish or given data to somebody else. Some of the notable publications recently were the ones by Dr. Horton right here, which is talking about a spatial analysis of ALS cases in the U.S. and their proximity to the multidisciplinary clinics. One of Dr. Romberg mentioned the fact that MDC clinics, multi-disc clinics, are very, very important as in terms of providing the care for ALS patients. And this particular study right here found that almost half of the patients live 50 miles or more to the closest ALS clinic. And that's really important when it comes to access to care. I mean, if there's no multi-disc clinic, access to care can be an issue. Fortunately, you've got a brand new clinic here, a multi-disc clinic here in Honolulu, which provides that access to care for patients, which is really, really important. So, but access to care also is an issue in rural areas, rural parts of America as well, where there are no ALS clinics, where patients may have to drive, a couple hundred miles to their closest clinic. We also had another paper which is published regarding the completeness of the registry and how that compares with our other study we did regarding state and metro. And that actually what this does is it looks at, we sampled state and metro areas in the United States, prevalent cases, and compared those to the cases sitting in the registry right now. And we know for a fact that, we are missing cases. We're missing cases in the African American community. We're missing cases in the Asian community. We're also missing cases in the Hispanic community. So we're doing a better effort to go ahead and reach these patients as well. So the Biorepository is the newest element that's been added to the registry. And the Biorepository, we're certainly excited about this. This was an ongoing effort for 4 years, a pilot project, and once the experts deemed it was feasible, we went ahead and launched last year. And the Biorepository, there's different components to it, but there's an in-home collection and a post-mortem collection where we come to the patient's home at no charge to go ahead and collect their saliva, urine, blood, as well as if we can't get to their homes, we'll go ahead and mail them a saliva kit. We also have a post-mortem component where you can get more information on. We've also added something called the GUID, Global Unique Identifier, which allows, for example, the registry or other researchers to go ahead and track patients anonymously through other clinical trials or other research avenues. So with the Biorepository, this will be unique to other biorepositories already in existence. So we will actually go ahead and link up all that risk factor data. All those 17 surveys will be linked to those patient samples. So hypothetically, we'll have information, let's say, on a patient, their brain or their saliva or their urine or their blood. Did they serve in the military? Where do they live? Were they exposed to possible pesticides? Did they have a traumatic brain injury? All that information will be here with us and actually matched and given to researchers. It'll also be nationally representative, meaning to say it just won't be coming from California or Texas. It'll be coming from everywhere. And so we certainly would encourage those in Hawaii to go ahead and, be a part of the Biorepository. I mentioned it's user-friendly, so the fact that we will come to you to go ahead and collect the samples, we'll contact you, we'll arrange a phlebotomist to come out to your home, and there'll be no charge to you whatsoever. And we feel this Biorepository in probably 2 to 5 years will be the largest collection of pristine ALS samples in the world for research. So trying to find out, the unknowns of ALS, the genetics behind ALS, the biomarkers of ALS, disease progression, and so forth. These are currently the studies we are right now doing in-house as well as externally. So far, we have looked at meta-analyses from the pilot project samples. We're also looking at the genomic analysis through NIH, and that allows us to look at the DNA, the actual genes behind ALS, which genes are associated with what. We're also looking at something called POPs, persistent organic pollutants, so compounds that actually exist in the environment and don't readily go away, to see if those actually impact the disease as well. This right here is a schematic of the actual Biorepository. So as you can see, we have the in-home collection here as well as the post-mortem collection. And this is so as patients come in, join the registry, and take risk factor surveys, all that data is added to the registry, and the Biorepository will go ahead and link this information to the surveys themselves. And as researchers go ahead and request those samples, we'll go ahead and send those specimens for research to the researchers, along with the information regarding did they have a TBI, their demographics, and so forth. Were they in the military? So we know research is a very, very important thing, and these days research funding sometimes can be a little bit difficult to come by, and the registry is committed to going to funding as much research as possible. To date, we've actually funded 13 research studies, and pretty soon we'll be actually releasing a new FOA, which is in government language, funding opportunity announcement, for researchers to go ahead and apply for other proposals to look at regarding etiology, looking at risk factors for ALS. That will be coming out. There was a question that was asked about, hey, how can Hawaii participate in research? Well, certainly we would encourage your research participants here at Kaiser, as well as maybe University of Hawaii, to go ahead and join or apply for these grants right here. You guys have a great team here, and certainly we would encourage you to go ahead and apply for these upcoming grant applications. So just want to kind of go over some of the highlighted research we've actually funded. University of Pittsburgh just came on board last September, and these guys are looking at environmental toxicants, PCBs, DDTs, in the ambient air pollution. And so this is certainly something where we're very excited to see. Dartmouth College, which is looking at, for example, cyanobacteria as well as pesticides and how they potentially link to ALS. Stanford University is also looking at conditions such as diabetes, hyperlipidemia, as well as autoimmune diseases, and how these are potentially linked to ALS disease progression, or even is it a protective factor, and so forth. We also have a study out of Ireland, which is looking at the Hispanic population of South America, as well as Cuba, and comparing that to the population of Europe, because we know for whatever reason, the Hispanic population gets ALS at a lower rate than the European population. So this is a list of all the funded studies right here. And last year we had CDC Public Health Grand Rounds, and this is available for viewing at CDC's website. You can type in CDC Public Health Grand Rounds, and you can go ahead and find this particular series. So Public Health Grand Rounds is kind of like the bread and butter of CDC, talking about whether it's Zika or talking about, let's say, heart disease. So we applied back in 2016. We were accepted, and so we actually had this session talking about the future direction of the registry, the impacts, the challenges. And more importantly, we had the provider perspective. Dr. Ed Kosarskas spoke about the challenges that neurologists face with ALS. We had Ed Tesoro, who talked about the patient perspective regarding, dealing with ALS. And this, for us, this is important to get word out about ALS, the message about ALS. Raise awareness is very, very important. So the metrics, we had actually over 20,000 Facebook Live viewers watching the grand rounds. And so for us, like I mentioned, this is for us to talk about the registry. More importantly, bring attention to ALS. So for 2018, we actually just launched a new website right here. This actually is active right now. We're very excited about this new website. It's a much more cleaner website. It allows patients to find information about ALS, information for caregivers. We'll have a section called ALS News for You, where we'll go ahead and put information regarding recent publications and so forth, new clinical trials we're helping to support. We're also working with partner organizations regarding helping out the states which are under-enrolled. So we want to go ahead and reach out to those communities which need a little extra assistance for enrollment. We're also working with groups which are also under-enrolled, like I mentioned, African Americans, Hispanics, and so forth. We want to increase awareness about the registry. And more importantly, we want to fund new awards. Like I said, everything we want to do is we want to find out the mysteries of ALS, the unknowns of ALS. And so by us funding new opportunity announcements, we can actually find out what causes ALS, who gets ALS, are there any protective elements that could potentially be a protective factor for ALS, and so forth. And we'll also be publishing our 4th annual prevalence report, which will cover calendar year 2015 this fall. So in summary, the registry is the first and only population-based registry in the United States. I like to say this is your registry. I'm just a caretaker of this registry. And ALS research is very important. ALS research counts on you. So by you joining the registry and having, the providers as well as the ALS Association, which is a very, very important partner, working with caregivers and patients and letting them know about the registry certainly is very important. So this right here is just kind of, like I said, this is your registry. We are caretakers. We want to go ahead and find out what causes this disease and hopefully have more treatments coming up in the future as well. And this is a patient testimonial video we actually did just very recently.
The ALS Registry, to me, is a great way for all of us to bring whatever our data is and whatever our personal experience is, even though it's just data. But to have that go into the registry and allow the scientists to analyze what it is that we are all about, how our disease is progressing, how long we've had it, what biomarkers we might have. All of that is steps towards a goal.
The first step is finding the cause through the disease registry. Research is the key because there's so much we don't know.
I think it's essential that we get as many people in the registry as possible. I just assumed I was in the registry. I don't know why, because I just got all this paperwork and all this stuff. The more we know, the more the researchers will have to get to an answer, and we've got to get to an answer. We have to.
The least that every patient can do is to get online and sign up for the registry.
No one seems to know the whys, and I feel like if we could find out the whys, there's more to the research, I think, than just the test tubes. I think it's a very, very cruel disease. I have to have hope.
The ALS.
I'm sorry. So in conclusion, we worked very closely with the association, to go ahead and find out the mysteries behind ALS.
Thank you, Dr. Mehta. Well, we've had a very full afternoon, and in these last few minutes today, we've crammed an awful lot into a few hours. We've given you a tremendous amount of information without a whole lot of time to really process it through. So we do have a few minutes, questions either for Dr. Mehta or for any of our other panelists today.
I have a question for the panel. But first for Dr. Mehta. So now the prevalence rate is 5 per 100K and that's the one that's going to come out in...
Yeah, so currently the prevalence is 5 per 100,000 for calendar year 2013. I think it's important to look beyond the numbers of ALS. Whether it's one disease, 10 cases, or 100,000 cases, we all can agree one case of ALS is one too many. So I think it's important just to realize, these are numbers. But numbers, we're not capturing all the cases, but numbers are just a small part of that. ALS is just, like I said, we do a lot more than just count cases. So it's important for people to realize, hey, you know what? Yes, we have the surveillance portion where we're looking at the case counts in the United States, but we also go above and beyond that. We're funding research and so forth. But yes, currently it is 5 per 100,000 in the United States. May that increase? We're not sure right now. Could it decrease? Potentially. We're not sure. We certainly need more years of data to go ahead and make that determination.
Yeah, because it came from 3.9.
Yes, that's correct. That's correct.
Yes,
yeah,
that's right. What would you prevalence?
No,
it's prevalence.
Here's the thing. We can't calculate incidence because incidence in our data is self-reported, and it's only reported on the portal side.
Exactly.
And incidence on Medicare databases and VH databases can be potentially extrapolated and going back to see when the patient was first diagnosed, and we're looking into that. But because ALS is a non-notifiable disease. I didn't mention that in my talk, meaning to say that so in the area of epidemiology and public health, something is notifiable if it's coming in, for example, if it's communicable. So an STI, tuberculosis, the flu, these are all communicable diseases, and they're reported back to CDC to the state level. So we don't get that data, therefore we must have our own methodology to go ahead and calculate that. So when it comes to doing incidence, we're currently looking at ways to go ahead and extrapolate that information from our Medicare data to see if we can go ahead and calculate that. Yeah.
So that's much more frequent than the prevalence. Okay, 1 in 20,000, 1 in 1,800.
Yeah.
That's correct.
It's about 2 per 100,000.
That's correct. It's about 5,000 cases a year.
2 per 100,000?
Yeah.
Yes.
Well, then how come the prevalence is much higher?
Well, remember, patients. These are periodic prevalences as well.
That's prevalence.
It's a point prevalence, a periodic prevalence as well. So typically, what we've seen in our data, the incidence is about 5,000 cases per year, and the mortality of ALS is about 5,000 cases a year. So the mortality becomes almost a surrogate for incidence in a way. So, but the premise is we're looking at incidence ourselves internally, but the prevalence currently is 5 per 100,000. Okay, but these are also case counts coming in. So patients are living, and keep in mind when we calculate our prevalence, it's not a prevalence for 1 year. It's someone who survived in 2012, who's carried over to 2013. If they're living in 2013, they're carried over to 2014. It's called a cumulative prevalence.
Okay, we have another comment and question from the internet. Thank you for your presentation. Can you explain more about what you meant that some states, like Hawaii, are underreported?
So, when it comes to underreporting, so we actually look at our own data internally, and we see what should be the expected number of cases coming from a particular state. And so our statisticians will simply say, hey, these particular states are probably underreporting their case counts based upon our data. So that's how we go ahead and calculate actually the expected number of cases for the state. Now, I think, so we are working with states, working with the ALS Association, other groups as well, to go ahead and do effective outreach, to go ahead and increase the number of enrollees in the registry itself as well.
I'm curious how many folks here who would be eligible to participate in the registry have signed up? And if anyone has maybe tried to sign up and has faced any kind of barrier that they might want to share to help the rest of us understand what to expect.
Sure.
Or whether or not it was super easy.
If you have any questions regarding signing up, any difficulties, please contact us. I know we're 5 hours ahead in Atlanta, but I can assure you our team is very, very diligent. They'll go ahead and contact you the next day with any questions you may have when it comes to signing up.
We have, well, I'm going to let Cookie go because I think we have time for one, maybe two more questions. Go ahead.
Okay, we signed up, my husband, he's passed away like 2.5 years ago, but we signed up with the ALS registry, and it was pretty lengthy, but I mean, it was worthwhile giving all that input for the research. But I often get questions from Taryn Davis, our care manager, because my husband was diagnosed at the University of California, San Francisco, and we joined the research project, which was an autopsy project. So while your bioregistry, my understanding is you're giving input, but you don't get output, right? We don't get any information back because...
The information you would get back would be, so for example, any publications that will be coming back, we cannot give you your actual data, your genetic data, and so forth, because it's prohibited by our IRB, our Institutional Review Board, to go ahead and give you the data back. It's just not permissible at this time. It's just one of those things because, you know, the data's coming to us. We'll report it out eventually in aggregate, let's say, in a publication of sorts. Going back to your surveys, we certainly appreciate, you know, your husband signing up. We have 17 surveys, and these surveys can be taken in any order at any time you want. There's no reason for you to go there and, you know, get registered and take the surveys at once. You can take your time at your leisure. You know, you can have a caregiver help you out as well. The surveys, some are very, very easy. Some are very quick. Some are a little bit more lengthy. The reason behind that is these are all surveys which have been standardized. We work with the ACES group out of Stanford University to go ahead and have these surveys. If I could ask you all these questions, you know, or all these, you know, areas in 5 simple questions, believe me, we would go ahead and do that. But the thing is, we want to go ahead and get as much data as possible for our researchers to go ahead and look at that data.
Okay.
There may be a misunderstanding between the terms autopsy and a biologic data repository. In an autopsy, you would get factors related to the cause of death. I think what you're talking about is having tissue that could be used for research independent of the cause of death.
My point was that I get calls from Taryn Davis, and I get calls from her because she has pals in Hawaii that they're saying that, you know, if they could just be part of an autopsy project, or they want to donate their brain or their spinal cord to somewhere, and we don't really have anywhere that I know of that's doing that kind of research here. But what we had at the end was that we did have a report back specifically to what my husband had and what part of his brain was affected.
Sure.
Like, I'm just making the
Yeah.
distinction between that this is just input for research for
Yeah.
a number. But, I mean, we do have a need. I do get calls. So
Yeah.
I was just wondering if...
Yeah, I mean, I understand what you're saying. So these, all the postmortem collections, not to get too more, but are actually analyzed in different places. So, for example, they're sent to the Boston VA, which actually is a permanent group that's actually doing CTE work. It's the same group we're working with for the ALS. It's the same national group of researchers as well. You know, regarding the actual, you know, getting that data back, you know, there are strict prohibitions we have, you know, through our IRB, what we can or cannot release. So, for example, genetic data. The reason why I cannot give you genetic data if someone, let's say, is positive for C9 or SOD1 is because there's no genetic counselor for us to have to talk to you about that, and the IRB will not allow us to do that. So, but keep in mind, all these data right here are your data. They will be released in time. We are working on a current publication for genetics, and all that data will be released to the public so you can see exactly what we have. Obviously, we can't say this patient's name had this or that. That's just something which is, you know, regarding patient privacy and so forth.
Thank you. We are out of time. Come on. We are out of time for today. I will say that if I encourage you to speak to your neurologist also, because those folks who are engaged in clinical trials, I know at Cedars and UCSF. Cookie, you guys were at UCSF, right? So I think that's a good follow-up question for Dr. Lomenhirth at UCSF. I'm going to wrap. Okay, I'm going to wrap up for today. But thank you all for your time and your attention. Thank you, Dr. DeVere and Dejini and her team back here for making this all possible today. Aloha, everybody. And you'll be getting surveys in your email about today. This is not going to be our last Ask the Experts event here in Hawaii. We'd love your feedback so that we can make these events even better for next time. Thank you so much.
Thank you.